Lancet Commission, and that's a good starting point, was a request from the Lancet editorial board and specifically from editor-in-chief. So it means that we are starting to have awareness also, not only in scientific society, but also in the board of major journals. And this was published clearly in Lancet. I advise all of you to just download it. It's a big document, and honestly, as an interventional cardiologist, being that commission, I really learned a lot on cardiovascular disease, especially because it is very well represented, the different geography and specificity of some of the disease in some area of the world. Being in Europe and in Italy, honestly, I have not seen those kind of disease in my practice, so it was honestly very, very interesting, and I learned a lot. The aim of the commission were, first, to reduce the global burden of cardiovascular disease in women by 2030. Clearly, this is very ambitious, but we have always to look for ambitious projects to try at least to get some accomplishment, I think. Second, promote cardiovascular health and improve outcomes for women worldwide. Third, identify existing evidence and gaps in cardiovascular research, treatment, access to care and prevention in women. And four, to increase the global awareness of sex and gender-specific disparity in cardiovascular disease and provide a springboard for future research. And these were the lead and senior commissioner. Roxana Meran was the lead commissioner. She built up all the team, and together with her, Monica Acevedo, senior advisor, Dr. Noel, that I think all of you know, as well as Angela Mas. And these were the 17 commissioners. I was one of the commissioners. We were some interventional cardiologists, 3 of the 17 actually were 4 were interventional cardiologists, but were all the different specialty of cardiology included. And it was tried also to have a good representation of the different area of the world. So the first point where we were starting to see was what was at that time when we met and we built up this commission, the CVD prevalence in women. And although there was a decrease in the global age standardized prevalence of cardiovascular disease in women between 1990 and 2010, there is indeed has been a slight increase since 2010. Regarding the mortality, the decrease in global cardiovascular mortality in women slowed down markedly over the last decade compared with previous years, but there was an alert on young women, because indeed in the young women there was a slightly increase on cardiovascular mortality. Women in clinical trials, we have been touching this point in these last 2 days. Though legislation passed in 1980s and 1990s mandated the inclusion of women in clinical trials, and this is in US but also in Europe, women are underrepresented, sex-specific study data are underreported, and the lack of data limits the potential for developing sex-specific strategies and recommendations for cardiovascular disease in women. And one important part of the document was trying to address if there are strategies that we can use to increase the proportion of women in clinical trials. This was a question from yesterday. So what this group of women came up together. First, be inclusive. Avoid upper and lower age limit in exclusion criteria for enrollment in trials, because clearly if you are going to lower the age, but especially if you are going to put high limit of age, you are going to exclude most of the older women that are experienced with chronic coronary syndrome and coronary artery disease. Exchange knowledge, educate recruiting personnel on importance of enrolling women, share experience of enrolling women after each study, conduct routine surveys on motivation for participation and non-participation in trials. Meet women where they are, because that's another important point. And by the way, it was quite clear that this is different according to the geography. because clearly women have their meeting point. We were discussing also yesterday, where is the best way, to addressing doing prevention in this area. Must be most probably different from different areas. For example, it came out in South America, where there was important problem regarding detection of hypertension, that the best way were outside church, because this is the place where most of women from South America meet. So just be a little bit out of the box and think in your region where you can reach the women and do the right education to them. So target outreach in community settings frequented by women, involve primary care physician and family members. That's another very important point. If you want a woman to be in a trial, you have to go also to their family members, as it was discussed before. Provide education and information about the risk, but also the benefit of participation, and remove the barriers. For example, if you have a patient that has to come back to follow up, arrange childcare and free transportation, or offer flexible hours and at-home follow-up. So now we have learned with COVID a lot regarding remote visiting. That's a good point, and that's a good way also to enroll more women. Disease states and key recommendation. So the group was divided according to expertise, and in each single individual area of cardiovascular disease, there were indeed identified some areas where we should put more effort to try to investigate. First, INOCA. We have been discussing about INOCA. There is the need of research. First, epidemiology. We don't know the real prevalence, and most probably the prevalence is going to be different according to the different geography. So we have to get data on the population, investigate underlying mechanism, and define which is the correct diagnostic algorithm and treatment. MINOCA, understand the underlying mechanism to provide therapeutic option, investigate treatment option and secondary prevention strategy, and also there was this concept of endorsing a MINOCA-specific ICD-10 code as requested by American Heart Association that, by the way, can help also in identifying this patient. The problem of spontaneous coronary heart dissection address uncertainties in prevalence. Again, we do not know which is the real prevalence, and also the treatment, as well as which is the lifestyle that this patient has to do when diagnosis is made. ST elevation MI, again, this is a big area. We still have an under-treatment, under-diagnosis. This is quite consistent in big data and literature. So target underestimation of cardiovascular risk in women, continue efforts to provide guideline-recommended treatment to women in ST elevation MI, and also try to investigate potential biological sex differences as underlying reason for sex-related mortality gap in ST elevation MI. Because again, as I said, there was this increase in mortality in young women, and mostly this was due to ST elevation MI. Heart failure, that's a big area of knowledge. And clearly, again, it was discussed before that the incidence in women or heart failure with preserved ejection fraction is higher, but is still not investigated the reason why, and by the way, which are the therapeutic options, and underlying the importance of further research in this area. Prospective sex-specific dose-finding studies for heart failure therapies are warranted again. There are very few data coming from women, and which are the recommended medication by guidelines are mostly driven by data that we get from men. Also, as we have seen, the women are more prone to have cardiogenic shock after acute coronary syndrome. Why that? Again, there is lack of data, and we need to better understand that and clearly to prompt diagnosis and treat this patient. Takotsubo syndrome is something, again, that was more frequently described for women. Establish international research collaboration to access large registry, and again, education not only for patients but for all healthcare providers. And there was again a specific call for peripartum cardiomyopathy. We had a full session on that. Initiate large-scale multi-center prospective registry, but also randomized clinical trial to examine the benefit of standard heart failure treatment as well as emerging therapy, and establish a global collaboration. We need more data. I mean, we really have to understand if we are underestimating this phenomenon, and to prompt diagnosis and then also build up, which is the treatment of this patient. Arrhythmia, there was all a discussion regarding ventricular tachyarrhythmia and sudden cardiac death. Again, there is the need for improving global data collection, identify accurate sudden cardiac death in women, and trying also the community to recognize and respond to sudden cardiac death to tackle the lower likelihood of bystander resuscitation in women than in men. Again, this is a data that is emerging. Women are less frequently, when they have out-of-hospital cardiac arrest, resuscitated as compared with men, and this is clearly quite an alert. And again, what about implantable cardioverter and defibrillator therapy in women? And then all the big issue regarding atrial fibrillation and the prevalence in women, improving diagnosis, treatment, initiating dedicated study to develop treatment strategy and address the underrepresentation of women also in this setting. Vascular disease, it was discussed, the stroke. Again, this was identified as an important area where we should implement diagnosis and treatment, especially of hypertension, because in the Lancet Commission it appeared clearly that the first risk factor for women is hypertension. And so there is a need to diagnose first, because this is largely underdiagnosed and clearly treated. And also vascular dementia, and by the way, that was interesting, vascular dementia and all cerebrovascular disease were the first cause of death in women in Australia. Why that? Again, big question mark. And by the way, the importance also correctly identify. And then all the area of cardiovascular disease and pregnancy, we have been discussing of that. Cardiovascular disease is the major contributor of maternal death worldwide. And again, late maternal death is not well documented and is a neglected issue. Global estimate of access to surgery and treatment of congenital heart disease in women is missing. Again, we need data. And also the cardio-obstetrics is an emerging multidisciplinary team approach that we should encourage. And then the problem of prevalence of rheumatic heart disease, the prevalence in this area in South America, and also starting also in North America, because of all the immigration coming from South America to North America, and I have to say also in Europe, because we have a big immigration from all the north of Africa. Again, multidisciplinary cooperation, for example, in preconception counseling and antenatal care. A global review, there was the global review for all the countries, specifically for Middle East and North of Africa. It was the Commission agreed that the need in this area to develop national awareness and screening campaign targeting diabetes and hypertension because of the prevalence, empower women through education about health and well-being, and establish robust health surveillance system to monitor cardiovascular mortality and morbidity in women. And clearly, this meeting that it was organized go exactly in this direction. Top 10 recommendation. Recommendation number 1, direct funding for real-time and accurate data collection on prevalence and outcome of cardiovascular disease in women globally. Accurate data on global prevalence and outcome are lacking. Second recommendation, develop educational programs on CVD in women for physicians, scientists, allied healthcare providers in all communities. Again, because they are understudied, under-recognized, under-diagnosed, and under-treated. 3, prioritize sex-specific research. Focus on identifying pathophysiology and natural history. Again, because these are poorly understood. 5, prioritize funding in global health organization for CVD health programs in women from socioeconomically deprived regions, because if we do not have data or specific data, these data are even less present in socioeconomically deprived regions, so we need to have them. Recommendation 6, educate healthcare providers and patients regarding early detection and prevention of CVD in young women, again because MI and CVD mortality is increasing in young women, and this is a big alert that came out from the work of the Lancet Commission. 7, establish policy-based initiatives and medical and community outreach CVD risk factor programs in settings frequented by women. Again, as we said, look to do prevention and to detect the cardiovascular risk factor, hypertension, dyslipidemia, and diabetes in women, and go into the community in the places where they are mostly frequented by the women. 8, research, again, because we need data, is needed to identify the impact of sex-specific psychosocial and socioeconomic risk factors on CVD in women and evaluate intervention strategies. Because one of the risk factors that have been evaluated are also psychosocial and socioeconomic factors because they contribute to global burden of CVD in women. And 9, scale up LTR programs in highly populated and under-industrialized regions. Age-adjusted prevalence of CVD in women is increasing, especially in some of the most populous countries of the world. And the 10, which is mostly the last, is embrace public-private partnership to develop broad-scale programs to save lives of women with CVD. There is no current established global policy to coordinate prevention and treatment of CVD in women, so we need to get it. So thanks for your attention.